Okay, good afternoon, everyone. Thanks so much for joining us this afternoon for a webinar on dizziness and vertigo with Dr. Omid Motabar. My name is Sarah Demetrio. I'm with Suburban Hospital's Community Health and Wellness Department. And every month we hold webinars on a different health topic. This month, as mentioned, is on dizziness and vertigo. Next month, please join us for a talk on podiatry with Dr. Isaac. So before we begin, I first would like to introduce our speaker, Dr. Omid Motabar, who is a general neurologist with clinical expertise in EMG studies at Johns Hopkins Community Physicians, as well as Suburban Hospital. He completed his fellowship in clinical neurophysiology EMG track from Columbia University, and his neurology residency was at Rutgers Robert Wood Johnson University Hospital. And this afternoon, as mentioned, he's going to share with us dizziness and vertigo. What is it, how to treat it, how to prevent it in the future, and everything in between. So just a few housekeeping items. There will be a time at the very end for a Q&A, so please use the Q&A box, not the chat box, but the Q&A box at the bottom. Type your question. We will go through as many as we can. And if you need to reach out to me during the talk, use the chat option, which is also at the bottom of the screen. So without further ado, let me introduce Dr. Omid Motabar.
Thanks for the intro, Sarah. So as she said, I'm going to be talking about dizziness and vertigo. So the lifetime prevalence of having significant dizziness is not insignificant. It's between 17 and 30%. There's a female predominance, about 65% are women, and the range that are most affected are 51 to 60-year-olds. And that's contrary to a widely held view that people 70 years and older are the age group that's most commonly seen in peripheral vestibular disorders. And then also importantly, about 1 in 6 patients actually have 2 causes of dizziness at the same time and not just one. The most common combinations are vestibular migraine, which is dizziness that's caused by a migraine. And the most common type of peripheral dizziness, BPPV, benign paroxysmal positional vertigo. And then the other combination is vestibular migraine and Meniere's disease, which is a rare cause of dizziness, and I'll go into all of these. So it's important to separate the different syndromes. So, unlike common teaching in the past, just recently, the International Classification of Vestibular Disorder System doesn't actually consider vertigo to be a subtype of just the broader rubric of dizziness, but it's actually a separate entity, like a separate descriptor from dizziness. So vertigo is a sensation of self-movement. It's a false sensation. So you're not really moving. It just feels like you're, spinning or swaying or tilting or bobbing, bouncing or sliding, some kind of sensation of movement. Just regular dizziness doesn't have any sensation of motion, but rather there's impaired spatial orientation. And the third one, unsteadiness, is when someone's unstable in any position, seating, standing, or walking. They're not weak, so they're not falling to one side. And the important thing for doctors to know is that if there's over-reliance on a person's description of dizziness, and you're just using it as the main piece of information, then this leads to mistakes in diagnosis. So that was the old teaching, where you kind of want to know, describing it, are you spinning? Are you lightheaded? So, that's still important to do, but since sometimes, as people know that who've been dizzy or vertiginous, it's really difficult to describe it. So what you want to do as a clinician is to ask questions that are focused on timing, like, you know, how long it lasts, and if there are any triggers, like positional movements or, you know, anything else like that. So moving on to duration. So it's, you know, separated by seconds, minutes, hours, and days. So seconds, and this is all general, there's always exceptions to the rule. There's vestibular paroxysmia, which is just like just a few seconds of kind of vertigo. So BPPV could be one of them. And there is a cardiogenic, so not neurological, but actually your heart, it's not pumping out enough, low ejection fraction, or you have like AFib or some other type of arrhythmia. You're not getting enough blood or oxygen to the brain, and it causes you to be dizzy. Minutes wise, you could have a TIA, which is also known as a mini stroke, transient ischemic attack. So that's very important and most life-threatening one. And vestibular migraine usually lasts, it can last minutes, hours, or even days. If people have panic disorders, it can definitely cause dizziness. If people's blood pressure drops after standing up for a couple minutes, that definitely can cause dizziness. And if someone has low blood sugar, they're hypoglycemic, like diabetics, that can also cause dizziness. It could be longer than minutes. And then hours, like I said, migraine, and another more rare entity called Meniere disease. And days, you can have vestibular neuritis, which is usually an infection or inflammation of the inner ear. Multiple sclerosis can cause dizziness, and also stroke. So here's some features of these disorders. So migraines that cause dizziness, it can last anywhere from a few minutes to 3 days. And it's usually in people who have a history of migraine, and you have migraine features such as sensitivity to light or sound. You have, gets worse with movement. There's a throbbing component, it's unilateral, and so on. And then the Meniere's disease usually lasts hours, usually. And a lot of that has to do with hearing loss. Okay, sorry, I was just reading the chat. The Meniere's disease can last hours, and it has to do with, you know, hearing. You can have hearing loss, you can have ringing or some kind of other sound in your ears, and you can feel a fullness in your ears. Then you have a mini stroke, which can last minutes to a couple hours. And it's important that you realize the symptoms of TIA, or also stroke, same symptoms. So if you have any of these symptoms, you should get to the ER as soon as possible. So they consist of double vision, so not blurry vision, actually seeing two of something. Your speech is slurred. You can't swallow correctly. You can't see to one side. And just in people that have stroke risk factors, it's important to get checked out if you're having dizziness. Vestibular paroxysmia, which is like the BPPV, it's a few seconds, multiple times per day. Then you have benign recurrent vertigo, which is just vertigo without other features, that is not persistent but keeps coming. Panic disorder, like we talked about, it lasts minutes, and you have dizziness, lightheadedness, unsteadiness. Then you have the low blood pressure when you stand up, and the definition is, so it doesn't happen right after you get up, but rather you have to wait 3 minutes to wait for the blood pressure to drop, and you can get dizziness from that. Like I said, cardiogenic, from low cardiac output, or from a very slow heart rate. It's not pumping enough blood to your brain, or very high heart rate where it's not letting the heart fill enough. And then you have low blood sugar hypoglycemia. And this is mostly diabetics on insulin. If they take too much insulin, they can become hypoglycemic. And this is just a picture of the vestibular system. So this is a system that's inside your inner ear, okay? So it's deep in your ear, and it's a network of tubes that are filled with fluid. The tubes are called semicircular canals. And then also there are calcium deposits in these otolith organs that you can see here. And when you have these tubes and these deposits, they're called the vestibular system. And this system kind of tells the brain what position the head is in and how it's moving, and it helps keep you balanced, especially when you're standing or walking. So this is the same system. So peripheral causes of dizziness and vertigo have to do with this system, okay? So peripheral is from abnormalities in the semicircular canals. So you have 3 of them, and the one that's affected the most is the posterior one, so this one. But you have an anterior one, you have a horizontal one, but this is the one that's kind of affected 90% of the time, this posterior one. And then the calcium deposits are in this area utricle saccule, and this is for hearing, cochlea, and this is the vestibular or cochlear nerve. And then I'll go through the kind of the most common causes, the main causes. So one is this BPPV, the other one is vestibular neuritis or neuritis, labyrinthitis, and the third one is Meniere disease. So you have, so benign, we'll go through each word, benign, so it's not harmful, it's not life-threatening. Paroxysmal, it happens in episodes, it happens when you move your head. And vertigo. So it's the most common, and it's most common, like I said, between 50 and 70, so not really over 70, but more mid-range. And people report spinning, that's kind of like the textbook version, but it's not required. It can be, it's just a sensation of movement. It doesn't have to be spinning per se. There's brief episodes, not more than a minute usually, a few seconds, and they're triggered by changes in head position, like laying down, mainly rolling over in bed is really pathognomonic for it. And then looking up to reach for something, and they're caused by, there's a lot of words for this, but basically people call it crystals. So this area has crystals in it, okay? So this is where they're stored in here, utricle saccule. And what happens is they can become loose for whatever reason, and they go into this canal, and it causes dizziness. And some people have a constant milder dizziness. However, if there's particles in this canal, can cause like very, very severe vertigo that people can't even function from it. So this is a diagnostic test. So this is what I would do if I see somebody who I'm testing for vertigo, okay? So, and in this case, it's right posterior canal vertigo. So what I would do is, the first step is to turn the patient's head 45 degrees. So whichever way you think they're having the vertigo, if it's in the right ear, you turn right. If it's in the left ear, you turn it left. And you can do both sides if the patient doesn't know. And then importantly, you have to go back quickly. So not slow, but quick. Patient has to keep their eyes open and just focus in one direction, not move their eyes and not close their eyes. Although it's very difficult. If you're having actual vertigo, it's kind of almost impossible to do it because your patient just can't handle it. And then if it's present, you'll see nystagmus. So nystagmus is just bouncing of the eyes within a few seconds. You have to wait a few seconds. If it happens right away, that's concerning for a central cause like a stroke. So it has some latency to it. So, and then this is the cure for it. So there aren't many cures for diseases in neurology, but this is definitely a cure. So what you want to do, the first step is the same as the Dix-Hall pike, 45 degrees. And this is a good diagram here. So you lay the patient back quickly. So the crystal goes up here, then wait 30 seconds and you turn the head 45 degrees or 90 degrees. So 45 degrees the other way and the crystal moves like that. Then 30 seconds, the patient goes toward the same side and the crystal comes back into the utricle and then they sit up and it's there. So it's a very effective procedure, high success rate, but if there's not improvement with repeated maneuvers, then probably it's something else. If it's, if this is done correctly, it's probably something else and you have to consider that. And I'll get into treatments a little later, but so a lot of people, if they have this, the ER, a doctor could give them meclizine. So meclizine is good for kind of controlling nausea, but it actually, you shouldn't use it really for BPPV because it kind of suppresses the vestibular system and it doesn't allow your brain to become used to the balance. So this is the other disease. So it's called vestibular neuritis or labyrinthitis, and the cause is not known, like a lot of things, but it's thought to be related to a prior infection, like if someone had a cold, like a viral infection, which can cause swelling around the vestibular nerve that maintains balance. So how you would recognize this is it's sudden, it's prolonged, so it's much longer than BPPV, and you have nausea and vomiting, and it causes ear symptoms. You can lose some hearing, you can have ringing in your ears, or you can feel that your ears are full and it's only in one ear, not in both, only one ear gets affected. And you do hearing tests and the hearing tests are normal and there are no neurological signs like eye movement abnormalities or anything like that. And usually it gets better on its own, but it may come back and there are medications for it. So it's treated both with actual oral medications. And the most important thing for a lot of these diseases is something called vestibular rehab, where you turn your head in certain directions, you move your eyes, focus on things. Usually would go to vestibular rehab and you just get your brain reaccustomed to position. So that's really important. And the symptoms like the vertigo and the nausea, you can treat with an antihistamine, an antiemetic, like Reglan or Zofran, Phenergan, something like that. And some people, some doctors even give steroids, oral steroids, and they've been shown to to treat the symptoms of vestibular neuritis because it tamps down on the inflammatory response. And then actually treating a virus is not effective for vestibular neuritis. Okay, and then the third one is Meniere's disease. So this is a much more rare cause, maybe less than even 1% of peripheral vertigo causes. So it's thought to be caused by a buildup of fluid actually in the ear, in the inner ear, and similar symptoms to vestibular neuritis, just episodes of vertigo, minutes to hours, and it has hearing loss, ringing in the ears, and fullness in the ear, and it's only in one ear. And usually it's a lifelong condition, but you can treat it with medications in most people. So what's the treatment? So first line is limiting salt intake to at least less than 2 grams per day, because salt just brings fluid into the ear. So less salt, less fluid into the ear. Reducing caffeine, limiting alcohol, And if that doesn't work, you can use medications like diuretics to bring down the fluid, like hydrochlorothiazide, and that's also used for people with blood pressure issues. And even sometimes you can have injections into the intratympanic, that's like the ear, with steroids, dexamethasone and gentamicin, which is a type of antibiotic, and this can improve your symptoms. So what medications are there? So these medications, they're not effective in vertigo, but they just kind of treat the symptoms, and they don't, they don't provide any benefit in chronic dizziness or just when you're off balance. And if you use these, you have to make sure that you don't use them for a long time. They're just tapered quickly, because they actually inhibit the vestibular system, and it doesn't allow your brain and the vestibular system to get used to, your balance. So you don't want to inhibit that system. You just want to do it temporarily. And then, so like I said, the antiemetics, which is things that prevent like nausea, so like Reglan, prochlorperazine, and this is the dosage, and these are some adverse effects, and this is the cost. And antihistamines, which tamp down on the vestibular system. So this is your meclizine or antivert. And then also what's very effective, actually, what I usually, give patients, if the other ones don't work, are actually benzodiazepines, which are used for anxiety. Actually, they also tamp down on the vestibular system. So something like Valium, Ativan, they both work well, but obviously they shouldn't be continued because they are addictive substances. So after those three, there is another one that people should be aware of is, and this is the reason why you may get an MRI for this, is something called a vestibular schwannoma, also known as an acoustic neuroma. So it is, and this is a cartoon of it. So it's, it's a tumor basically in the inner ear that compresses this vestibular nerve. And you can see it on the MRI here. And because it grows so slowly, you sometimes won't even notice it, or you just have mild vertigo symptoms, because the imbalance is compensated by the central nervous system. So it's so slow that your brain can become accustomed to it while your vestibular nerve is being affected. And then you can feel imbalance, which is, swaying or tilting, and that might only be the manifestation. It doesn't have to be kind of like, spinning or anything. And what patients present with actually to the doctor's office is they can't hear out of one side, or they have ringing of the ear. So that brings patients to medical attention. And MRI brain, like I said, is diagnostic, and the treatment for this would be surgery to, remove the tumor. So this is much rare causes. You don't see this very often. And then, so that all covers peripheral reasons for vertigo. So now I'm going to move on to central causes having to do with the brain, basically the actual brain. So this, like I said, is vestibular migraine. It's vertigo that's actually caused by a migraine, and it's kind of in people that have a migraine history, and it causes vertigo that can be positional, it can be spontaneous, just come on, or it can come on by seeing different things like flashing lights. And then even between episodes of the migraine, people can have constant symptoms. So actually a lot of people do, they just have chronic dizziness and imbalance. So their symptoms kind of don't get completely better. They just have exacerbations. And then most people, like I said, have typical migraines, and they have other migraine symptoms like this visual aura, the squiggly lines, or they're sensitive to lights. So treatment-wise, is kind of, it's treated like migraines and vertigo. That's what it's treated as. So when you have an acute attack, you can treat it like vertigo. So you want to suppress the vestibular system with, like I talked about, Ativan and meclizine for the acute attacks to, tamp down on it. And then you can also use triptans, which are the medications that are used for migraines. Imitrex is one, sumatriptan. And that's when you have a headache also. And then there's preventative treatment. So this is very important with people that have a lot of headaches, maybe at least 8 per month. And that is avoiding triggers. Very common ones are chocolate, red wine, aged cheeses, citrus fruit, sausages, deli meats. I've heard of a lot of different things. And then I use this a lot for people with migraines. There's 3 classes of medications that are used for preventative therapy. So like tricyclic, the antidepressants like Elavil or amitriptyline work well. Beta blockers can work also. That's like propranolol, and Topamax also can work. It's the anti-seizure medication. And hormonal treatments when you have, a lot of people have migraines around their period, and also acupuncture have been helpful anecdotally. And then vestibular therapy, like I said, is very important. That's, working on balance, like heel to toe, standing on foam, things like that. Gaze stability, like you hold your like thumb in front of you, you stare at it and you turn your head like that, up and down. And that helps your brain become used to it. And that's called habituation too, when you just move your head around, focus on things to help your brain and vestibular system kind of become used to the dizziness, and then it'll desensitize you. And that's why it's important to not chronically use like meclizine or Ativan, things like that, because you can't do that. It won't be effective. And also, if you take it for a while, you can become sensitized to them, and then you can get withdrawal symptoms when they're discontinued, especially Ativan and also benzodiazepines. So now a more harmful thing would be MS, multiple sclerosis. So this usually happens in younger patients. So like 20s, 30s, 40s, not really in older people, very rare. What MS is it causes inflammatory lesions. So kind of it's an autoimmune disease, and the antibodies attack the central nervous system, and they cause lesions like how you can see on this MRI, the white spot. They can cause lesions anywhere, but for the importance of vertigo, it'd be in the brain stem. So it'd be either here or in the cerebellum. That's what controls kind of outside of the vestibular system, also controls function of balance and dizziness. And in about 20% of patients with MS, they can experience vertigo. And so, when someone with MS thinks, have vertigo or dizziness, it's much, much more likely actually that it's not caused by the MS at all, but actually you have the MS, but you have something else. You have the BPPV, so your brain's not being affected, but actually that vestibular system is being affected. So just keep that in mind. And treatment of vertigo is kind of the same treatment that you do for MS, which is just kind of a course of steroids. And then you can also use this vestibular suppressant. So also, medications can cause all different types of side effects. And some of the medications that are associated with dizziness are, Alzheimer's medications, memantine, rivastigmine, some seizure medications, the older ones that I don't even use, nobody really uses them anymore. Antidepressants can cause dizziness, like SSRIs, the tricyclics, and other ones, blood pressure medications because they drop your blood pressure. Anti-inflammatories like Advil can cause dizziness. Antipsychotics can do it, and they can cause a lot of other side effects. Actually, like benzodiazepines can also actually cause dizziness as well. Mood stabilizers and muscle relaxants, these can all cause dizziness. And there are many other drugs too. These are just some of them. So you want to, so this is the most kind of important slide. This is really like life-threatening causes, like strokes, TIAs. So if you have any of these symptoms, you want to get to the ER kind of as soon as possible. So the first one is something called vertebral basilar ischemia, also known as a TIA. So this is caused when you have kind of atherosclerosis or plaques, cholesterol that's stuck in those vessels in the brainstem, the vertebral arteries and the basilar artery. And those are the arteries that feed the brainstem and the cerebellum. And like I said, you have to look for stroke symptoms: double vision, slurred speech, weakness on one side, ataxia, like loss of balance. The diagnosis is an MRI of your brain to look for a stroke. A TIA, actually, a lot of people don't know this, but the definition of a TIA is that nothing comes up on the MRI. You can't see it. It's called a mini stroke. So a TIA is just based on clinical description. There would be nothing on the MRI. If you see something on the MRI, it's called a stroke. So you'd also want to look at the vessels with MRA. And treatment-wise, you want to kind of, reduce the risk of another stroke. So definitely, if you have a TIA or stroke, you want to be on lifelong aspirin or Plavix. And then you have to reduce your stroke risk factors. The most important one is blood pressure and also bad cholesterol, LDL. So your good cholesterol, you want high, but the bad cholesterol, you want low. And then blood sugar, like diabetes and smoking. So the orange part is a TIA. And then the gray part is an actual stroke. So you can have a stroke in your brainstem or your cerebellum. So the cerebellum is the back of the brain that has to do with balance. So you have kind of really sudden, so that's a key word. Also vestibular, like peripheral can also be sudden, but this is more persistent. This lasts days, just doesn't come and go. It's just persistent, always there. And then you just really have bad balance. It's not just the dizziness that's giving you bad balance, but you're actually, very unbalanced, and you'll fall towards one side, the weak side. And obviously this is usually older patients, but it can occur in anyone. And then, so some people have chronic dizziness. So there's different definitions, but this is dizziness for just at least 3 months. And this happens in older people. And there are a lot of contributing factors: history of heart disease, stroke, diabetes, syncope, which is passing out, anxiety, depression, bad hearing, just a lot of different medications at one time can cause chronic dizziness. And one of the diagnoses is something called PPPD, which is persistent postural perceptual dizziness. It's chronic. It lasts 3 months, and you have fluctuations that are both from the disease or also from the environment, moving around. So this is kind of a newer diagnosis. A lot of people don't use this yet, but this is kind of a newer diagnosis now. So testing wise, contrary to kind of what people think, you don't actually need any lab testing. Nothing's going to really come up. But if someone has chronic dizziness, like for many months, then you want to look for other causes. You want to look for hematocrit, which is, if you have anemia, you might get dizziness. Glucose, if you have low blood glucose. Electrolytes, BUN, which is kidney function. Vitamin B12 can cause, if you have a lack, it can cause a lot of things, but also dizziness. And if you're hypothyroid, if your TSH is really high, that means that you might be hypothyroid, don't have enough thyroid hormone, and that can cause dizziness also. And then imaging studies. So like I said, when you don't know what the cause of dizziness is based on the description or on the clinical exam, people have like double vision or nystagmus or slurred speech or weakness or ataxia or problems walking, then you definitely want to do like an MRI. And I usually do an MRI basically on everybody who comes in with dizziness or headache if they haven't had one, because you don't want to miss something. Head CT is kind of useless. It like almost never see anything on it, so you have to get a brain MRI. And usually, a lot of people order it with contrast. That you don't usually order it with contrast, but you can if you want to look for something specific, like in the inner ear. But if something is in the brain, actually, if you suspect something in the brain, you don't really need contrast. And you want to look at the vessels too. So look at a CTA or MRA, if you're thinking stroke. And this will be my last slide. So this is the most important thing for people. So this is when you go to the ER. So when you have a new or sudden severe headache, so that could be the sign of a subarachnoid hemorrhage, like a thunderclap headache, double vision, that's definitely could be a stroke, trouble speaking or hearing, weakness, numbness on one side, not be able to walk well, passing out, just vomiting that won't stop. If you're older, had a stroke in the past, or have risk factors for stroke. So this is all important to keep in mind. So that's all I have. Any questions?
Thank you, Dr. Motabar. That was very informative and thorough.
Sure, my pleasure.
Thank you for sharing your expertise. So what questions do we have? Looks like we have 3 already. So our first one is, can a person with a history of migraines experience temporary dizziness with motion sickness after a cruise vacation?
Okay. Motion sickness. Yeah, I mean, there's a close link between migraines and dizziness. They're both kind of, thought to have like a common pathophysiology. So yeah, I mean, people with migraines could be more, apt to have dizziness. It could be a vestibular migraine. And people definitely can get motion sickness after a cruise. So yeah, that's obviously, that's definitely possible.
Great, thank you. Okay, next question is, have you heard of persistent dizziness because of orthostatic hypotension as part of long COVID?
So orthostatic hypotension, so that's blood pressure after you're, lying to standing for a while. That definitely can cause dizziness. And then as a part of long COVID, I've seen so many things from COVID, cognitive changes, headaches. So, I mean, I wouldn't be surprised that someone would have this. I haven't encountered it myself, but I bet if the long COVID clinic, people have seen that. I haven't seen it myself, but I don't think it's out of the realm of possibility.
Yeah. Right, thank you. Let's hope not. Next question is, should an evaluation be done by a neurologist or an ENT doctor?
Yeah, both. So what usually happens is that people come to a neurologist and then they would get referred to an ENT, but it could happen the other way around. Actually, I kind of like always refer to ENT, but almost always the ENT exam is normal. They're just looking for structural type of disease, but it's important because they actually do audiology testing. So they look for sensory neural hearing loss, and that could be a sign of, vestibular neuritis or Meniere's disease. So definitely there's a role for ENT with vertigo.
Perfect. Thank you. Good to know. And there's two questions regarding the slides. So this talk is recorded and I will be sending that out to everybody. So yes, you will have access. Okay. So our next question is, are there specific foods or spices that contribute to vertigo?
Yes. I mean, I think a lot of the foods that can cause migraine, I think can cause vertigo as well, because there's such a close association between migraines and vertigo. Mm-hmm. So I would say, chocolate, like red wine, deli meats, kind of MSG, things like that, I think can cause dizziness because there's such a close relationship between that and migraines. But I don't specifically know just for dizziness.
Gotcha.
Yeah.
That's interesting. Thank you.
Yeah, it is interesting. It's a good question. Very good question. Yeah.
Mm-hmm.
I'll have to look more into that. Yeah.
Okay. Next we have, how do you distinguish between basilar migraine from TIA?
Yeah, so that's a good question. So it's really difficult to distinguish that because they both have the same symptoms. They both affect they can both affect the basilar artery and it can cause a spasm of it. So yeah, it's difficult to do that. But if someone has a history of migraines, then after some time, that's probably a basilar migraine after some time. But in the beginning, yeah, you can't really tell the difference. So definitely, need an MRI to make sure you didn't have a stroke.
Right, absolutely. Okay, next is the Epley maneuver done independently after being taught? If so, how often?
Yeah, so yes, that's good. So yeah, so I always give instructions to people on how to do the Epley maneuver, but there's also something called the Brandt-Daroff exercise. You can just Google that, and that's an easier form of the Epley maneuver that people can do for BPPV. It's easier and it also works. But you can do the Epley at home too, and you should do it 3 times a day until you're free from vertigo for 24 hours, or just do it for 1 week. And that should be enough. And if it doesn't work, either you're doing it wrong or it could be something else. You should have some relief from it.
Okay.
Yeah.
Good to know. Thank you. The next is the difference between vestibular neuritis and Meniere's disease.
You mean symptom-wise? So it's totally different pathophysiology. Vestibular neuritis, they're thinking it's from an infection, a viral infection, and Meniere's disease is it's idiopathic. People don't know the cause, but it's thought to be from a buildup of fluid in the ear. But they have very similar symptoms. If you treat it with the diuretic and it gets better, then it's Meniere's disease. If Meniere's disease also is usually lifelong, like I was saying, vestibular neuritis goes away, after a few days. So Meniere's disease is much longer lasting than vestibular neuritis.
Gotcha. Okay, thank you.
Yeah.
Next is, I have recurring positional vertigo for several years. How could I help it so it does not happen again?
Yeah, so there's no guarantee that it won't happen again. Sorry, what was it? Can you go back to the question?
Oh, sorry.
Yeah.
I have recurring positional vertigo for several years. How could I help it so it does not happen again?
Yeah, so you have to kind of find out like which one it is, first of all. So that's by like going to a doctor and figuring out what it is. And if it's BPPV, you can cure that with the Epley maneuver. If it's Meniere's disease, you can, diuretics sometimes work. Sometimes, like I said, people just have chronic dizziness. So there's no guarantee. Some people just like live with dizziness, and it can try to be managed with medications as best as it can. But yeah, so.
Okay. Next we have, I suffer from DPPV. I have been experiencing pulsing in right ear for a few weeks now. Would this be considered a symptom of DPPV?
I mean, there's no hard and fast rule kind of for anything in neurology. Everything has to do with the inner ear. So it could be a symptom. It's not textbook, but I mean, there's a lot of different symptoms that don't fit in a box. So if you have kind of typical symptoms that when you move, it's very, very severe, and when you lie still, it's not so severe, and it can get better with the Epley, then yeah, it could be BPPV, and yeah, you could have ear symptoms even though it's not textbook. Definitely possible.
Okay. Does being dehydrated affect dizziness?
Yes. Yeah, that's the same thing as orthostatic hypotension. So that's, yeah, very common. So you have to make sure to be hydrated.
Yep. Great. Next is left temporal lobe meningioma with stroke TIA symptoms. Is this related or causal?
Well, don't go past it. Just reading it. Temporal lobe meningioma with stroke TIA symptoms, related or causal. I mean, if it's pressing, if it's causing like mass effect or pressing on the temporal lobe, I mean, it can cause seizure, stroke-like symptoms, which would be kind of have to do with language. Temporal lobe has to do with language. So maybe you can't speak correctly or read or write correctly. So yeah, it can cause stroke TIA symptoms, related, or I would say causal, like the meningioma could cause those symptoms. It's not the other way around, that stroke makes the meningioma. I think that's, yeah.
Okay, great. Thank you.
Okay.
Okay, next is I am told I have an abnormal heart rhythm, but they never go into detail about what that really means. Now I have vertigo after a bout with COVID. Could the heart issue be as the source? What can I test for?
Yeah, so the heart issue definitely can be the cause. This could be cardiogenic. So I think you need a heart monitor for that to see if that corresponds. When you're dizzy, do you have that heart rhythm? If so, probably it's from that. So heart monitor would be a good idea.
Perfect, thank you.
Yeah.
Yep, and we probably have time for just a few more questions. We'll get to as many as we can. And of course, you can email me and I can send them over to Dr. Motobar as well, if they're pressing. Next is if a patient with vertigo should worry about having cancer in the brain.
So that's much more rare, but cancer in the brain, like a primary cancer, usually doesn't affect like the area, brainstem or cerebellum. It mainly affects kind of like the main brain tissue, which doesn't really cause dizziness. But anything can happen. You could have, that's why I usually order an MRI on everybody. But yeah, there are primary cancers of the cerebellum or brainstem, and there are metastases, but you would expect it to go to a lot of different places. So you wouldn't just have vertigo, you'd have language difficulty, weakness. So probably wouldn't just be limited to vertigo.
Okay, great.
Yeah.
Thank you. Next is, can you spell the alternate exercise?
Yeah, sure. Let me type it. Can I type it in there?
Yeah, of course. Or you can do the chat or.
Okay.
Perfect. Thank you. What is the treatment for PPPD? Does it differ from vestibular migraine?
Yeah, so from what I understand, that's part of chronic dizziness. So I don't know what it's probably, I think it's symptom management and vestibular rehab. That would be my best guess. Vestibular rehab is kind of the treatment for all types of dizziness. And does it differ from? Yeah, it's a different thing. Migraine is, migraine, it's a migraine that causes dizziness. So dizziness is from the migraine itself. And the treatment for the PPPD is, that's a chronic dizziness, and that would be vestibular rehab.
Mm-hmm. Yeah. Perfect. Okay. Next we have, what are the most likely triggers for vertigo for a person with diabetes, hearing loss, and diabetes? Can you take the meclizine for the prevention?
No. So the meclizine is, like I said, is not for prevention. You should not take meclizine. Meclizine is only when you do have it and you're very nauseous. That's the only reason why you take meclizine. You would never take it otherwise, or that would just make things worse because your vestibular system and brain can't become reaccustomed to position. So no, it's not a preventative medication. And then you said, what are the likely triggers for vertigo for a person with diabetes, hearing loss, and diabetes? I mean, it could be the same triggers for anybody. If you have diabetes, you're at higher like risk for a central cause like a stroke or TIA. Hearing loss actually, it can cause vertigo, definitely. So it's not like you have to have Meniere's disease or vestibular neuritis. So hearing loss can cause vertigo. If it's uneven hearing loss, you could have dizziness or vertigo. I see a lot of patients with that because of their hearing loss. And if you get like a hearing aid, you can treat it. So.
Perfect. Thank you.
Yeah.
Okay. Then we have, we did that one. Okay. Sorry. What causes the buildup of liquid in the inner ear?
Yeah. So that one, I don't know if the answer for that is clear. Why that actually happens. It's not like water is getting in there. I don't know. I don't want to speculate on that one. Yeah.
Okay. Thank you for that. If you have about one vertigo incident per year, might the frequency occur with age?
I'm not sure how to answer that. I'm not sure how to answer this one. I don't really understand it. I mean, I guess, I mean, as you get older, you're at higher risk for vertigo. The main age range is between like 50 to 70. But yeah, I mean, vertigo can become more common as people get older.
Okay, thank you. Great. Okay, and so our very last question, thank you, everybody. Is there vestibular rehab providers in Bethesda area?
Yeah, that's a really good question. There are like tons of them. So a lot of physical therapy centers do vestibular rehab. It's a lot of the same exercises. It's like, focusing on one thing, just moving your head, like looking at something and then moving your head like that, walking and moving your head up and down, like laying down and moving to the left, laying down and moving to the right. It's those kinds of exercises, and a lot of PT, like kind of therapists know how to do that. And there are so many. Yeah. I mean, we refer to NRH at JHCP, but there are like so many of them.
Okay, thank you. Okay, do you have time for one more, or do you have to hop off? I know you have a patient coming.
Yeah, I have to. Yeah,
no worries. Well, Dr. Motobar, thank you so much for your time and your expertise. That was a great presentation. Learned a lot. Thank you, everyone, for joining us this afternoon. And I will be sending out the recording as well as a quick evaluation. We look forward to hearing your feedback. So have a great rest of your day and join us next month for Best Foot Forward. Okay. Thank you.
Yeah. Thanks, everyone. Bye.
Bye-bye.
Thanks, Sarah.
Thank you.